now I'd like to introduce Hailun Cui, is that right? Who's going to talk to us about neuromodification of refractory obsessive compulsive disorder. I'd like to point out you don't have an hour and 15 minutes, I'm afraid. Just the 15 minutes, because the time on here was 12:50, but it's just the usual time. 10 minutes, thanks.
Thank you, Doctor, for your introduction. I'm really thrilled to be here, and it's a pleasure. And thank you, BNP, for giving me this opportunity. My name is Hailun Cui. I'm a third-year PhD student working in the Department of Psychiatry at Cambridge University. The study I'm going to present to you today is related to a well-known psychosurgery for the treatment of refractory obsessive compulsive disorder. And I will be focusing on discussing some of the functional and cognitive remodeling after this ablative surgery in OCD patients. Well, speaking of the capsulotomy, one cannot avoid the question of why choosing capsulotomy over deep brain stimulation, because deep brain stimulation is currently recommended according to some publications. These two procedures share the similarities as a treatment of last resort. They're equally effective, and they both have over 50% of patients responding to the procedure, to both procedures. These days, there seems to be a tendency towards DBS rather than the capsulotomy, given the fact that DBS is allegedly more adjustable and reversible. But capsulotomy, according to several papers, with some development these days of more fancy procedures using capsulotomy, they can match the precision of targeting DBS using the name called advanced MR guided focused ultrasound technique with less device-related infections. So seeing this revival in the capsulotomy surgery and mounting studies on the DBS, trying to optimize the target selection, it made us wondering if we can optimize the capsulotomy surgery based on our research in his underlying mechanism. So the main focus, the objective of this study will be what functional cognitive processes are affected by capsulotomy surgery. In order to understand the mechanism of the therapeutic effect of capsulotomy in this study, we recruited 3 groups of people. The first one is the capsulotomy group. There's 27 of them as sample size. They all scanned and assessed at least 6 months post-surgery. And the second group is the OCD control group. We have about 33 of the subjects in that group. Those patients are diagnosed with OCD but never had a surgery before. And the third group is the healthy control group, which has a sample size of 34. Firstly, we ran selected cognitive tests using CANTAB software covering the executive and memory and attention function to find out if there's any cognitive changes in the OCD patients, especially after the capsulotomy. And then we move on to do some structural MRI scanning using a volumetric-based morphometry to find out if there's any gray matter changes across the 3 groups. And finally, we ran 2 fMRI task paradigms, namely the aversive task and the expectancy violation task, we sort to ask if the capsulotomy might be associated with the functional remodeling of the neural substrates related to the aversive processing procedure. Briefly, the participants will be presented with one of the 2 visual cues, indicating that the outcome feedback phase, they will be seeing either aversive or neutral pictures. And in between, there is a target arrow slide that indicating the direction of the button pressing. So during aversive conditions, participants will be showing gray images for a correct or timely response, and negative images for incorrect or no response. In the neutral conditions, the participants will be only showing gray images regardless of their correctness and punctuality of their response. And in the second task, which is the expectancy violation task, this is taking place and was scanned 45 minutes after the acquisition of the first aversive task. And here, the aversive cue, the aversive anticipation, the target slide are all followed only by gray images, mimicking the unexpected, non-negative outcome feedback that is against the negative expectation. This slide summarized the treatment outcome of the capsulotomy and across the 3 groups. First of all, we don't have any demographic differences among the 3 groups. And then we look into the treatment outcome using Y-box score, Hamilton total score, Hamilton anxiety depression score. We can see that over here, after capsulotomy, the patients have this great improvement scale using Y-box, and it's even lower than their OCD control counterparts. And over here, we can see not only do they have an improvement in their symptoms, they also have this improvement in their clinically relevant function, which is assessed using the Sheehan disability scale. And we also see this significant improvement in the quality of life as well, post-capsulotomy. And notably, we didn't see any very significant changes in the anxiety and the depression after capsulotomy. Only a reduction in the depression after capsulotomy, but there's no differences between after capsulotomy and the OCD control counterpart. So, which may indicate that the capsulotomy surgery has little or limited impact over the circuit of depression and anxiety. This slide, we summarized up the structural result. After multiple comparison, we were able to find out these 4 areas to be significant. There are significant differences across the 3 groups in these 4 areas. This bilateral chordate, nuclear accumbens, basal forebrain, and the thalamus proper. We then look into the relationship to see if there's any connections between the reduction or differences in the ventral medial in their structure, gray matter volume, with the Y-box score and also their cognitive performances, but we didn't find anything interesting. So we then treating all the measurements of the gray matter volume as the controlling factor in the following functional analysis. Here is we move on to the presenting the results of the functional imaging task. During the phase of the anticipation, over here, we found nothing interesting using the voxel-wise approach. However, by using the hypothesis-driven region of interest analysis based on the nuclear accumbens, we were able to find out that a post-hoc analysis found out that the healthy control relative to the aversive anticipation, there is a significant differences in healthy control groups against aversive and a neutral kind of cues. And in contrast, in the capsulotomy group, we see this significant reduction in the hyperconnectivity of the brain activity towards the aversive anticipation, which may indicate that this capsulotomy could be a remediation of the excessive reactivity towards these uncertain aversive stimuli. This slide summarized up the results for the feedback phase. Using voxel-wise analysis, we're able to find out 2 clusters of significant group biofeedback type interaction, which located in the left pregenual cingulate and the left IFG. Post-hoc analysis in the OCD group, which is the third column over here, and the third column over here revealed that, first of all, in response to the aversive outcome shown here in the red box plot, OCD group in the IFG showed this within-group hyperactivity compared to all other outcome of different villus, and also compared to the healthy controls. And in contrast, in response to the neutral, the lighter pinky color over here, in response to this neutral outcomes, OCD controls showed this lower IFG, also the lower PGACC activity relative to the healthy controls, highlighting this differential response to the aversive versus neutral stimuli in OCD controls. And during the expectancy violation phase, OCD subjects show a greater activity in the PGACC area, suggesting that the brain activity in OCD subjects following the aversive acquisition persists in excessive reactivity to prediction error. For the OCD patients after the capsulotomy, which showed over here, the first column over here, the first column over here, we can find that in the left IFG, critically, capsulotomy group showed this decrease in their hyperconnectivity to the aversive outcomes compared to OCD controls, which may mean this is like a capsulotomy effect. Over here, in response to the expectancy violation, we were able to find that post-capsulotomy patients relative to both the healthy control and the OCD showed this lower PGACC activity when expecting a learned aversive outcome, but rather experiencing no outcome at all. So therefore, capsulotomy appears to reverse this excessive reactivity to uncertain aversive outcomes over here in the IFG area and normalize the PGECC activity that might be relevant to the learning of a safety signal. Here, using generalized psychophysiological interaction method, we found out that OCD control patients showed this excessive functional connectivity between the nuclear composite area with the medial prefrontal cortex, and specifically in this case, the ventral medial prefrontal cortex and the pregenual ACC area. And we can say that compared to healthy control, the functional connectivity between these two areas is largely enhanced. However, after capsulotomy over here, we can see this hyperconnectivity between these two areas was decreased, saying that capsulotomy is actually working through downregulating the functional coupling between the nuclear components and the medial prefrontal cortex. And over here on the right-hand side of the slide, we can see that there's another area in the IFG that is showing between group differences, but there's no differences between capsulotomy group and OCD control group in this functional coupling, which means that capsulotomy is only capable of remodeling the functional connectivity along the midline from the ventral striatum to the prefrontal cortex, but not from the ventral striatum to the lateral prefrontal cortex. So far, our results confirmed that compared to OCD control patients whom did not receive capsulotomy surgery before, capsulotomy itself have been significantly improved. Has this efficacy in improvements in white box SDS and QOL scores. And secondly, we further investigate if there's any cognitive tasks showing knowing to be impaired in OCD and show there's no significant group differences between capsulotomy and OCD control, which indicates that capsulotomy has no impact over your cognitive functions. And we also say that we also discovered that negative affective processing, which we used aversive processing and the EV task, to be implicated in the neural substrate underlying the effectiveness of capsulotomy. And notably, these prefrontal areas we find in our two tasks is actually overlap with the prefrontal corticothalamic tract identified in the OCD DBS studies using white matter tractography. So on the left side of the slides, I just screenshot and used and just showing you that some of the publications using DBS to cure this refractory OCD, and they were able to find out this tract that has the optimal treatment outcome. So what we find in the rostral ACC actually overlap with the tract a region they were covering. So thus, our findings highlight the clinical efficacy of the capsulotomy, its relative safety profile, and the possible mechanism insights that might link DBS and capsulotomy along with the potential targets for a precision targeting and with no more ablative procedures. This is the end of my presentation. Thank you for your attention.
Okay, thank you so much, Hailun. I think we have time for one question. I think there's a raised hand, yes.
Thank you, interesting work over here. So question, this hasn't been done with capsulotomy before, but using cingulotomy, there's been some literature suggesting that a specific lesion location can have an effect on outcomes. And then you show something similar with the DBS work from Andy Horn's group. So I'm curious, have you guys have lesion locations and probably in a larger sample than what's been done before? Have you looked at that? Is there a difference between, because there ends up being incidental variation where the capsulotomy is actually placed, no matter how hard the neurosurgeon tries. Do you know if there's any difference in specific locations?
You mean the targeting of the capsulotomy?
Yes. So when the surgeon targets the capsulotomy, they go for the ventrocapsule, right? But sometimes they hit a little bit more superior, a little more inferior. There's a little bit of variability there. I can really say that in this main study, capsulotomy surgery itself is actually used the radiofrequency ablative surgery and is actually targeting the similar area. But we do notice that there is publications using more dorsal or more ventral targeting of this location. But maybe more dorsal will be having like some cognitive impairments, but like
closer to the ventral area that might be little like impact over the cognition. So we don't have, this is the exact reason why why running this study, trying to find out the exact location within the anterior limit of internal capsule to make sure that the patient is actually gaining, has this improvement white box while there's no other side effect impairment. So over to your question, actually we don't know, we have no information over the precision of the targeting in capsulotomy, at least so far.
What you do for you to get that answer.
Yeah.
Thank you.
Thank you.
Thank you. Okay, I'm afraid we're going to have to wrap up for lunch, but just if everyone could join me thanking all three of us.